So the FLOW trial, of course, looked at the effects of semaglutide on kidney outcomes and other important outcomes in people with diabetes and kidney disease, manifest by high levels of albuminuria and reduced eGFR, and overall found a 24% reduction in the risk of a primary outcome that was kidney failure, loss of kidney function, or death due to kidney or cardiovascular disease, as well as benefits for prevention of major cardiovascular events and all-cause mortality. And what this analysis showed that we reported at ASN this year was that those results were entirely consistent across different kidney function subgroups. So even people with reduced kidney function appear to benefit just as much as those with preserved kidney function. That should give us confidence to use the drugs more broadly in people with diabetes and kidney disease, and not perhaps to be quite as concerned as some people may have been about using them, for example, in those patients who might have a low GFR. So the FLOW trial results looking at mortality are, I think, really exciting. We've got very few treatments for people with kidney disease that reduce the risk of death due to any cause. In other words, that help people stay alive longer. And that's what semaglutide does in people with diabetes and kidney disease, as demonstrated in the FLOW trial. So the additional analysis looked at an array of more detailed data looking at different causes of death. We'd already identified a 29% reduction in cardiovascular death and showed that facts like sudden cardiac death and heart failure were common causes and appeared to be reduced in a consistent way by semaglutide compared to placebo, but also lower rates in some non-cardiovascular deaths, but they need to be interpreted with some caution. This is sort of very detailed data that the study was not powered to detect, but certainly, for example, suggests that there's no increase in the risk. Infection-related deaths, for example, were reduced from 3.7 to 3.3%. By semaglutide. And of course, then there was a big group of patients where the cause of death couldn't be determined, and that group also had lower rates of death if they were in the semaglutide arm compared to placebo. So overall, very reassuring findings, clear reductions in the risk of death, clear reductions in the risk of cardiovascular death, no suggestion of an increase of any other cause of death, and if anything, lower rates of non-cardiovascular death in the semaglutide treated arm. I think there are significant barriers to the use of GLP-1 receptor agonists in kidney disease populations and more broadly. Obviously, we've heard over recent years the issue of availability of these drugs, that there's been an undersupply, and despite several years of ramping up, the pharma companies have not yet been able to catch up with the demand for these agents. So that's a significant limitation, and it's obviously a factor that can drive inequity in access to GLP-1 receptor agonists that's really important for us to be aware of. Cost is also an important factor. These are not inexpensive drugs. That needs to be borne in mind, and hopefully we can find ways to reduce cost. But in the meantime, it will remain a barrier, again, driving inequity. It should be noted, however, that the magnitude and breadth of the benefits that these drugs offer to people with kidney disease, the kidney protection, the cardiovascular protection, reduction in the risk of death, as well as the weight loss and other factors that can also help to improve quality of life, are really profound. So they need to be weighed up against cost, and it is an important issue that does need addressing. But perhaps the most disappointing and easily addressable issue in many ways is the reluctance by some nephrologists. It's really reluctance. I think it's more caution in using these agents. They've typically been prescribed by endocrinologists. Many nephrologists don't have much experience in using GLP-1 receptor agonists and therefore are anxious about them. And of course, there are parallels between this experience and that of SGLT2 inhibitors. Many of the same arguments were made when we first reported the Credence trial back in 2019. But of course, the solution to that is for people to use them and to get experience with them. And in general, they're actually very simple to use. Most people tolerate them very well. There are obviously the GI side effects in a small proportion of patients, but they tend to be manageable in most. And most people not only tolerate the drugs, but are quite happy to stay on them. Interestingly, the adherence rates in the trials of GLP-1 receptor agonists may be significantly higher than those of other agents, perhaps due to some of these other benefits with regards to the way patients feel. So we've got some real barriers that are going to potentially stop us from realizing the full benefits of these exciting new agents. It's up to us as a community now to develop and implement strategies and test strategies that will address some of those barriers. So the APPLAUSE trial is really exciting to me. We've long known that complement is seen in the biopsies of people with IgA nephropathy, but there's been long-standing debate about whether it's a bystander and just a product of the disease process, or whether in fact it plays a meaningful role in the kidney damage seen in people with IgA nephropathy. And I think the APPLAUSE trial answers that question for the first time. It's the first time we've got convincing data showing proteinuria is clearly reduced in people with IgA nephropathy treated with the complement inhibitor, in this case, iptacopan, which of course blocks the alternate complement pathway by binding to factor B. So it's proof of principle of the pathogenic role of complement in IgA nephropathy, and I'm sure will lead to other studies of different agents attacking different parts of that pathway being studied. And of course, we also still await the long-term kidney function data to prove that these proteinuria reductions will translate into kidney protection, but the data look very promising from a proteinuria perspective. I haven't seen the data yet for kidney function at all, and look forward to seeing that over coming months and years. Additional analyses are now being done looking at biomarkers, looking at the role of different elements of the pathway, looking at measures of activity of the complement pathway in IgA nephropathy, and for example showing the C5 to 9 membrane attack complex levels were lower in the urine in people treated with iptacopan and came back to pretty much normal levels, suggesting the possibility that this drug may reduce intrarenal complement pathways and activity, the formation of membrane attack complexes, and the local inflammation that results from that, and then that may be the mechanism by which the kidney benefit occurs. But we've still got a lot to learn in this space. It's a really exciting time in IgA nephropathy. We've now got multiple classes of therapy, the B-cell active agents, which look very promising, complement inhibitors, steroids, of course, including budesonide, and then the non-specific therapies like sparsentan and now atrasentan, and also SGLT2 inhibitors, of course. So we finally have some quivers in our bow for a condition that was long considered untreatable in people with kidney disease, and which is responsible for a substantial proportion of kidney failure, particularly in young people. And the challenge will be, how do we put all of these together into treatment algorithms? And I think that's going to be the subject of many kidney weeks to come. I think the age data from Credence is really important. There tends to be amongst the medical community overall, particularly some pockets of it, a sort of ageism that creeps in that says once people are old and frail that they don't really need treatment and they're better off without treatment. There's this sort of whole deprescribing push that goes on, and in many cases that has real merit. When it comes to treatments like SGLT2 inhibitors, which have profound benefits for the kidney, for cardiovascular outcomes, for a range of other areas, I think we need to assess those sort of claims rigorously. And this analysis of the Credence data that showed benefits are similar in older people without any evidence really of meaningful increase in adverse events should provide comfort to people to both continue SGLT2 inhibitors in older individuals, but also to start them in older individuals to provide protection against all of those adverse outcomes. And I think that's really important data from that point of view. I think we're really in a golden age of progress for kidney disease. We now have multiple therapies for diabetic kidney disease that we know to be effective, and we have now the opportunity to look at how we can use those most effectively, what the combination of benefits might be, perhaps a 2/3 reduction in the risk of kidney failure if we get people on optimal therapy. And the challenge for us now is getting robust implementation of those findings, finding people who are likely to benefit and getting them and keeping them on therapy. And that's, I think, going to be a big job for us for many years to come. And the same is true now in many other kidney disease. We've spoken about IgA nephropathy as an area that's exploding in interest and value. I'm also involved in a trial called ZEUS, which is looking at the IL-6 antagonist ziltivekimab for cardiovascular protection in people with kidney disease. And we sometimes forget about the other complications, particularly cardiovascular disease and heart failure in people with chronic kidney disease. So I'm excited by the fact that we have new treatments being tested to address some of those complications as well. But we've come a long way. Back in 2019, we only had RAS blockade for diabetic kidney disease. We only had the same treatment really for IgA nephropathy. We now have an array of different treatments for both of those conditions, and the opportunity to make a real difference to our patients' lives. So look forward to continuing to develop that evidence base.